welcome to the Opportunities in Healthcare panel. And we have a wonderful two panelists here. And then we have a Norm from Buffalo, right? Are you in New York, Norm?
I'm in Naples, Florida.
Oh, close enough. Anyway, I'll let you, 3-hour flight. I will let the panels sort of introduce themselves individually, and I will start with Greg. And as far as the word about me, I'm off the boat from Poland and like 40 years ago, so directly into San Francisco, and where I spent about 30 years, 35 years in the tech companies, and eventually I was able to successfully exit in a couple of them. Then I started the fund, and then mostly invested in IoT, media, and healthcare. So that's my little background. But Greg?
Thanks very much, Arthur. Oh, there we go. Now we're gonna have to pass this around. My background, I'm a physician by training. Med school at Ohio State, did a residency in emergency medicine in Chicago, and then practiced clinical medicine, clinical emergency medicine on the west side of Chicago for many years. I've worked in and then ultimately moved into administration, and so I have some hospital administrative experience as well. So I've seen pretty much everything clinically, at least in an acute setting. But got bored with that, believe it or not, bored with that lifestyle and that from an intellectual perspective. And went back to school in San Diego and got an MBA, got plugged into the local biotech life science community almost 2 decades ago, and have spent the majority of my career on early stage drug development. I've got some diagnostic experience, I've got some med device experience, but have been doing earlier stage startups over the last 12 to 13 years. I'm on my second venture-backed company now, and we ended up in Texas because of a program here called CPRIT, which stands for the Cancer Prevention Research Institute of Texas. And they are really trying to build out the oncology ecosystem here in Texas. And we got a large grant from them. And so we moved here and moved the company and moved the team, and have been here 9.5 years. Wonderful, thank you.
Thank you, Arthur. Good to meet you, Gregory. Good to see everybody, everybody online. I'm Doug Sylvester from Xcellerant Ventures. I'm a lawyer by training. Even worse, I'm a lawyer manufacturer. I've been a law professor for 25 years and was the dean of Arizona State University Law School for about 11 years. Stepped down 2 years ago, and one of the areas I really felt incredibly passionate about was growing a venture capital community in Arizona. And so joined up with a couple of partners, one of them an ER doctor named John Schufeld, who was also from Chicago, so you might be an overlap. John he owns the jet. I think that's the way to look at this. So he started NextCare Urgent Care in the early 1990s, become very obsessed with providing digital health outcomes, providing ways to make health easier to access and easier to perform, and then really increasing patient outcomes. So John and I, and then a third partner named Chris Yu, who is a PhD from some university out east called Yale. I've never heard of it. Really worked on a lot of really early stage computer technologies and data areas, had a number of exits of his own. So the three of us got together, formed Xcellerant Ventures, did our first close last January. We now have a portfolio of 11 companies. I think there's 10 on our website, one we're about to announce, that really run the gamut of early stage diagnostics tools to digital health delivery systems that we are really hoping are going to improve healthcare. And we're doing one last thing, which is, of course, truly insane that I now know it's happening, is we're raising and investing at the same time, which does not create any logistical questions for us at all as we move forward. So we will never do that again, but the fund has done well. We've raised about 25 million. Like I said, we've got about 10 companies. Happy to talk more about both the fundraising and portfolio construction, but it's been a really interesting year and a half.
Thank you, Doug. Norm, if you can introduce yourself.
Great, thank you very much, Arthur. My name is Norm Friedland. I am also an attorney. We went to NYU a little bit before you, Doug. It was before the fax machine, so that'll kind of date me. But my focus since leaving a small little firm called Cravath, and Moore, has been in the venture capital space, technology transfer, and my clients for 3 or 4 decades were the gamut: the investment banker, the venture capitalist, the university, the corporate, both in the U.S. and internationally, principally in Europe. And when you get to be 60 years old and you realize half your life is over, you want to do something significant with the other half, and that is finding sources of mission capital that will support companies, commercial companies that have important social deliverables. And our focus has been on companies in the healthcare space. In many cases, the drug company, the drug development company that's going to fall into the valley of death because it just can't get the right kind of capital in the right kind of amount to get across the valley of death. And what that means is solutions, discoveries, inventions from incredibly smart people that have occurred over the last 4 or 5 years. And again, you heard one of them yesterday, Mark DeSouza, from the Senalicence, which has an ultrasound cancer-killing technology. Doug knows something about it because their first site was in Phoenix at the Ivy Brain Institute. And here's a technology, it sounds like science fiction. It kills cancer cells, initially in the brain, pediatric cancer, with no surgery, no radiation, no chemo, no side effects, and no collateral damage. I mean, that's, it's science fiction, but the kids are alive who have experienced this. So that's just one example of a company that the technology didn't exist 5 years ago. And we see dozens and dozens of these companies, and they're all struggling for the VC, the private equity capital. And my story today for the family offices is that you can invest in these companies. You can invest in these companies with reduced risk. You can invest in these companies with enhanced return if these companies will source in parallel to the ROI investment, what we call mission funding. And mission funding, and we can talk about this, is subordinate to the ROI capital structure, both debt and equity. And
Okay.
we're very excited about sharing that story with the panel and with investors, and taking your questions as to why it is that this has not been utilized before. So thank you, Arthur.
Well, thanks so much, Norm. I'll turn over to Greg, and I just wanted to kind of assess what the current situation in private and public markets are. I mean, what's the actual outlook right now on the industry in general? I understand that there's downgrades and valuations, and how one goes about like running the business, like in your operational situation where you have to kind of push things forward, and then there's an expense in an actual moving from one stage to another. What are today's market conditions?
Very good. And I think this will fit into what Norm started to allude to there. So the last couple of years have been really challenging in the life science sector. If you look at the XBI, which is the NASDAQ biotech index, it peaked in February of 21, and into the fall of last year, it was down 61%. So a lot of companies on the public side just really got beat up. And for the smaller companies, a lot of those companies are, their valuations are down 80, 90%. And there are hundreds of companies now in the public sector that are actually trading below cash. And so from an opportunity perspective, if you can identify companies that have enough capital to get them to a meaningful milestone, and get to a point where they can, now they're gonna probably have to recap, but if they can get to a point where they can generate some positive data, because it looks like things have stabilized. Since October, the XBI is up, I think close to 40%, and actually ended up last year slightly on the positive side. So because the market stabilized, valuations are down. For the companies that can survive, I think there's opportunity there. On the private side, the venture portfolios, and Norm, you can probably speak to this better than I, but valuations have been hurt. Raising additional capital has been challenging because the generalists have, left this space, and so it's the healthcare focused, life science focused funds that are investing now. So getting in venture capital has been challenging. They've been more selective. They're trying to keep their existing portfolio companies going. But there has been capital raised, and I think it's stabilized as well. They are currently deploying about $5 billion a quarter. Back in 2020, 2021, that was about twice that amount. But it's still at $5 billion a quarter. That's still above the average between 2010 and 2017, 18, say. So it looks like going forward with the market stabilizing. On the other piece that I think needs to be talked about are the big pharma companies and what's going on in the M&A side of things. Valuations were tough for them for a couple of years, but now that prices have come down, they need to continue to feed their pipelines because small private companies end up feeding probably 50 to 70% of the pipelines. Now, big pharma companies, they're really getting out of the earlier stage R&D and focusing more on later stage clinical development, commercialization, and so they have to feed those pipelines. With valuations down, there's lots of dry powder in the coffers of the big pharma companies, and so we're seeing opportunity there. And as I was mentioning to you earlier, typically for earlier stage companies, the big pharma companies want to see clinical or phase 2 data. They want to see not only safety but efficacy, and that's sort of past the valley of death, right? So it's typically a challenging time. But we're now talking with bigger companies. They're saying, look, we are a mid-sized company. We're a large billion-dollar size company, but we can't compete with the big pharma companies if we wait for that phase 2 data because they just have deeper pockets and us, we can't afford it. So we're looking for the more modest markets, $300 to $800 million peak revenue markets, and earlier stage where it's phase 1 or ready to go into phase 1 asset, and they're willing to jump in now. So I think that's going to provide some opportunity as well. And I'll stop there. I mean, we'll talk a lot more about the capital markets.
Okay. I will, continuing the subject, I wanted to continue on to Xcellerant and your investment company and see what, I mean, the situation right now is that you're both raising the capital and then you also are funding the company. So which side of the is it diagnostics or therapeutics? Where is your money going now?
Yeah, so our thesis is focused on diagnostic tools, early stage companies, and or digital health delivery that doesn't need FDA approval.
Okay.
For precisely, our experiences are mirror each other a little bit here in that, by the time these companies at the therapeutic level have achieved even phase 1 clinical, they're outside of the scope of the fund size that we're focused on. So again, because of my partner's experience, we think we can really have a great amount of deal flow. Maybe when we look at this is, we all experienced COVID and we all go to the hospital and the doctors and we all know this is a broken system, right? This is not an area that has been truly disrupted in a truly beneficial way. And so the number of companies that are out there trying to look at every single layer of how health is delivered to patients, both here and across the globe, is extraordinary. They're not all going to be great. They're not all going to win, but there's an extraordinary amount of ferment out there trying to come up with these different kinds of ideas. So the deals are out there, the companies are out there. And one of the things that we really like are looking at companies that have kind of survived COVID their own different valley of death, Norm, to put it in that way. And have shown a real resiliency and have found their way out into the market at some level. And to your earlier point, Greg, is like now what they need is an influx of cash to get to that next major milestone. That's what we're looking at. We tend not to look at therapeutics because, you know, it's just a really risky business. And you're going to need some deeper pockets to try and figure those out. We're hoping our next fund can really take a look at those. But it's been a very difficult time to fundraise for venture. A lot of different family offices are out there, and I think we even had some conversations last hour about how we've become really overinvested in some things because they haven't exited. A lot of the conversations I've had with family offices that traditionally invest in healthcare, they're saying, well, yeah, but we have funds that are now 10, 11, 12 years old and have not exited, so we're not putting any money in until those are done, and we're worried about the current economy when that's going to happen. So we have the same problems that a lot of, quite frankly, the companies we're investing in are running into as well. And then just to complete the insanity of my life, I also have a medical device company on the side that I've been working on for years. So I know what it's like to raise money on that side as well. So it's been a really interesting time out there, but the values there are extraordinary if you can just find the right companies.
So just a quick question on the medical side, medical device side. What's the cycle? Is it longer than therapeutics to get all the approvals? Or what are the challenges between those two?
Yeah, it depends on whether they themselves have invasive qualities, and those can take quite a while. But for a lot of medical devices, you know, we have one that's called Nanodropper, and they just went up into space on SpaceX, and it's very cool. And all it is actually is an adapter for eye drops that now deliver the appropriate amount of medicine to your eye. Everybody's used eye drops. They run down your face. Very simple. Does need FDA approval, both for is it delivering the right amount of medicine and is it using the right kinds of qualities? But those are usually quite fast. Those are 510Ks. These are really fast, easy FDA approvals. And so one of our theses is you already have to have it. It tends to be a year, maybe 2 years at most. The medical device that I've got on another company called ScriptGuard is an opioid delivery device. The only thing it actually needs is it using appropriate materials? So on the device side and diagnostic side, they tend to be much shorter than the therapeutic side and much cheaper.
All right, Norm, it's your turn now. Tell us more about how one investing in your fund is able to save on taxes, because that's part of your program.
Well, okay. So let me just make a couple of comments. Greg, I mean, the number is something like 600 of these life science companies that have many of them extraordinary solutions are going to run out of money in the next 18 to 24 months. And yes, $5 billion a quarter in new venture investing sounds like a lot of money, but when you divide it when you divide it among 1,000 companies, it's not going to make it. What we are telling investors who are looking at companies.
Norm, maybe you can turn off
like
the video
yours.
because you're breaking up.
Okay.
Try to turn off the video.
Okay. Is this any better?
Yeah.
Okay. I have a face for radio. So what we're saying to investors is, look, consider another round of investing in these companies alongside sourcing capital from the philanthropic private foundations within family offices. And that's money that's already been set aside for philanthropic activities. Nobody's needing to write a new check. That money's in the foundation. The requirement, as you may have read for Elon Musk, is that private foundation has to write 5% of its assets every year in qualified distributions. Those distributions can be made as grants, which is what 99% of them are made as, but they can also be made as something called a program-related investment. And a program-related investment is a funding for a for-profit company that is made on the condition that there's no economic benefit to the foundation funder. So the terms of that funding are essentially a 5 to 7 year below market loan, no collateral, no personal guarantees, which can be subordinated to current rounds and future rounds of debt and equity. So when you do the economics for that type of transaction, for the ROI investor, you reduce risk because now you have a tranche of first loss capital in your capital stack, number one. And number two, if the company succeeds, you can increase the ROI return to that private investor by a factor of 5 or 10 or 20. And so what we are sensitizing people to via Marty's conference is this type of philanthropic program-related investment capital is there. And it's not there in trivial amounts. And it's not there only from your mega philanthropists like Bezos or MacArthur or Gates. I mean, every private foundation, and this is really our strategy, every private foundation can participate in fundings of companies that have a mission that aligns with their mission on a collective basis in at-scale amounts. So let me tell you what I'm talking about. You go to a wealth manager who's got 1,000 family offices that they advise. Within those 1,000 family offices are 500 private foundations. Within those private foundations, you've got 100 that are interested in cancer, neuro, cardio. And with a company that has the right kind of management, and that is probably represented by the fellows sitting at the table, who have an authentic determination that mission is part of that company's agenda. You source $500,000 from 100 of these private foundations. Nobody's betting the ranch. It's being funded alongside ROI money. So that's a validation. And you're reducing the risk. And so we've got two examples, and Michael.
Hey, Norm, quick question. Norm, quick question.
Yes.
Hey, Norm, I have a question that parallels that, and it touches out something that we've been looking at and talking about with family offices. Is, if I understand correctly, what you're talking about are really grants or donations where it's just sort of given non-dilutively to the company. The other thing that is emerging, and there's some significant precedent for this now, is venture philanthropy, where there's a mission-driven focus, but they come into the equity round. They join the cap table just like everybody else, but the allocation is, if there's a successful exit, that money plows back into the foundation. Nobody realizes personal gain from that. And that's how Vertex was able to do so well with their cystic fibrosis, right? That initial investment from venture philanthropy returned $3 billion. So that's it. What's been your
yeah, thank you, Greg. So venture philanthropy, we think that's a different story. That's taking the economic and the endowment that has an economic return and focusing it on a particular mission. This is the philanthropic capital. And Doug can tell us, because he's got a tax degree from a little school near the Washington Square vicinity of New York. This is capital that cannot be deployed for an economic reason. It has to be deployed only for a mission reason. And that capital is there in billions and billions of dollars. But it hasn't been unlocked. And it hasn't been unlocked in combination with ROI investing. And that's really what it is that we are discussing with family offices that Marty is introducing us to, family offices that are coming to us saying, tell us about this PRI strategy. We've never heard of it before. And we explain it to companies and they say, you mean we can get this capital and it's subordinated? And by the way, the repayment obligation may be satisfied by delivery of services. So it may very well be that you've got $20 million of this PRI money, but you're delivering services to the right population, and you get credit for that against your obligation.
Hey, Norm, can we get John Cataldi to introduce himself so we can see he's on this panel? So
I think he's the next one.
he's on this panel too.
As well. Okay.
Originally he should be on this panel.
Hey, John.
I could go either way. I have no real preference. Just want to enjoy adding to the collective thought piece here. John Michael Cataldi, Native American Venture Fund. We primarily domicile our portfolio and our ventures, leveraging tribal sovereignty for what it unlocks with federal government, from set-asides, from sole source contracting, to grant dollars, to access to change legislative policy. So happy to be here amongst the this fine group of panelists, and listening in to learn more. And since I was a latecomer, I'm happy to put in my my 2 cents where it's worth, whether it be venture philanthropy or ESG investing, which I look at a lot of our projects as being 1 foot in, with hopefully without the stigma with impact investing or philanthropy investing and not having an ROI. I think there's a way, where we've shown, proven a way, that there is a way to have that philanthropy-based, venture-based, impact-based, ESG-based type of investing practices, doing good, but not being punished by doing good for having a lack of profit in any venture. The devil's always in the, is not necessarily in the deal, it's in the details. And with solid deployment from what I've known from these gentlemen here and others in the room, I think they have those I's dotted and T's crossed well within those details to make a venture or philanthropic investment actually a profitable one as well.
I have a quick question.
Sure.
So I'm just looking at the National Science Foundation's website here.
I don't think you can hear you.
I have to put it loud, they can hear me. Yeah, but I'll say it anyway.
So I'm looking at the National Science Foundation website, and it says that there's about $200 billion of allocations for R&D. About 40 billion was to COVID-related funds, right? And I'm sure there's even more to private grants out there. So, you know, we're seeing that because so much of this money has been pulled, like there's no next set of funding, that companies that have received 30, 40, $50 million of non-dilutive equity, I mean, so it falls in with Norm's perspective, they're going to go out of business. So sure, they raised $5 or $10 million of VC money, but they raised $50 million of grant money. So anybody with half a mind would say there's $50 million of value, but these guys aren't getting continuing funding. So, you know, outside of Norm's prescription, you know, what do you, I mean, is there a venture capital or private equity model or a state model where government step in to rescue some of these, you know, businesses, or are they just going to go kaput? I mean, in some respects,
Marty.
Hey, Norm, wait, Norm, I'm going to tell you to wait, or I'm going to silence you. so in some respects, you know, the issue is that there's been brinkmanship played by a lot of these companies that received the funding, right? Because they said, oh, we're going to do a debt round and not have to reprice ourselves. And they've been doing that for 2 years. right? And they didn't get, and then there was no funding because everybody wanted to wait and see what the repricing was, right? So what are your thoughts on that?
Can I talk?
No,
Doug?
you're last.
I have a few thoughts, but please.
Norman's last.
Well, John, why don't you go? You were gonna say something?
John, yeah.
Well, we're in a unique position, given that we manage a Section 17 federally recognized tribal corporation in the biosciences. And so the set-asides and sole source contracting for both government-based contracts and for research is a big piece of our revenue and drive whatever portfolio we go into. So that type of access allows us to, I've never actually lost a grant that was under a tribal umbrella, and I never lost a contract that was under a tribal umbrella. Example with the Seminoles, tribe of Florida, when I was the CEO there for all the economic development actions, we generated in excess of $2 billion on the top line for the 47 other businesses under the umbrella that had nothing to do with gaming. So it's a powerful tool, and Native American tribal ventures are looked at as Super 8A. Not those that are owned by a Native American, that's different, but those that are actually owned by a federally recognized government entity, or as the Supreme Court refers to tribes as domestic sovereigns. So that's a little bit of a niche. But Norm, you were going to say?
So let me jump in. And so we've kind of been on the other side of that, and we received a significant amount of non-dilutive funding. And I suspect that the challenge the companies are facing are that at the end of the day, the investors, whether they're have to invest 10 million or 30 million, they're looking at it strictly from what's the financial risk here, and the money that's in is certainly validating, but it's all about what's the story from here going forward, and what's the valuation and what's the risk of the capital that I'm putting in, despite the fact that there's all this non-dilutive capital.
I understand the sunk cost argument. Absolutely, right?
There are some companies out there. There's one actually in Scottsdale that we run across called VivaMed, that what they tend to do is look for these companies that got to phase 1 and then ran out of money and stopped. But there are companies out there that look for these kinds of distressed molecules on the therapeutic side in particular, where these things have gotten to a certain level, but they were unable to prove, or they couldn't find the financing. There are people who then build companies around these because now they can get into phase 2 and they really think that they're promising. There is a small economic solution, but I'm in an academic institution. And so a huge amount of that NIH goes to these academic institutions. It was never actually meant to spin out companies. And when they do, those people come back and they just profess about their wonderful experiences out in the private market.
Historically, what you're describing has been a trickle, but today it's a wave.
Yeah. And it's just, there's going to be swamping of massive amounts of companies. I actually do think VivaMed is one. There are many others out there that are constantly looking at the landscape to see what assets are out there that we can pick up and maybe build something around. So we might see a rebound of this in about 4 or 5 years of things that got to a certain level that they couldn't build a company around it, but people they don't have the sunk cost problem. They can just look at it as of today and build a brand new company around it. And I think that's what we can see.
So Marty, a couple of thoughts. First of all, as Doug alluded, a lot of that NIH and government money goes to institutions. And those institutions will siphon off for, quote, administrative purposes. Doug?
Payroll.
34.
I got to get paid, Norm. So, 54% sounds fair to me.
Yep. So 30 or 40 or 50% of that money doesn't go to the scientist, it goes to the administration. Number one. Number two, we heard from Tim Draper in Miami at your conference, the breakthroughs in personalized medicine, in oncology particularly, but in other areas. These are incredibly powerful solutions. And those solutions should be funded by the ROI investor. But, the market is down, and those investors can find other places to put their money. AI is the hottest thing going. If you've got an AI company, people are throwing money at you.
Norm, can I
so the
interject
only
on that?
alternative, I'm sorry, what?
Because can I interject on that? I mean, you're you know, when we're talking about money, you know, going into this and the administrative fees, the NIH has been incredibly good about the new policies being put in place that they don't allow this huge just blanket administrative fees. And I think that, you know, whether it be AI or biotech or wherever the industry is in, one of the biggest things that companies need to actually do is plan ahead of time, you know, measure twice, cut once in putting grants and governmental contracts as part of their go-to-market strategy. Tesla is an amazingly good example. SpaceX is an amazingly good example. There's probably several dozen companies that I could think of off the top of my head that were funded into the billions of dollars by putting their best hat on in pre-planning how they're going out for the grants and set aside contracts that would allow them to achieve their goal. And for research, if you're using research money to pay for the same people that are going to be on your payroll 24/7, that would take out you become competitive as a company because you don't have to pay for those researchers, or it offsets the researcher's salary. And at the same standpoint, you're able to further the value of the investor by allowing these NIH or whatever grants being entered into here to offset your cost of operations in your bottom line. Less on the bottom line means, or less on the top line means a lot more on the bottom line at the end of the day. I didn't mean to interrupt you, but I just wanted to throw our 2 cents in now that we're coming to the end of this track.
Sounds good. Hey, I think we had a good topic in general, but I think one of the most important things here is to get to know one another, and we had a brief discussion just before the panel, and it turns out that one of the affiliates of the Ivy family network happens to be in the business of that actually directly fits into what Greg is doing. So let me ask Greg, and let's talk about your particular project, right? And so we can expand it out, not on just philosophy of what's happening, because we kind of know it, but let's get to know one another. Tell us more about you.
Thanks very much. Yeah, I think we're kind of representative of a lot of companies that are at a sort of an inflection point. So my company is called Curtana Pharmaceuticals, and we're developing a small molecule drug for the treatment of different types of brain cancer. Glioblastoma in adults, medulloblastoma, diffuse intrinsic pontine glioma, and others in children. And the original technology came out of Dana-Farber and then was developed at UCSD in San Diego. I started the company with the head of neuro-oncology at UCSD, and we're at the point now where we have a drug that looks very promising in a number of different primary brain cancers. And the beauty of this drug is that it hits a target that's unique to the brain cancer and not in normal brain tissue or in other tissues in the body. So we've developed something that's very selective for just hitting the brain cancer, number one. Number two, we've addressed head on the problem of getting a drug into the brain. 95% of cancer drugs don't cross what's called the blood-brain barrier. That's the barrier that the brain has to protect itself. But it protects itself too well when it comes to cancer drugs. So we knew from the beginning our drug needed to get into the brain, and our drug does that in spades. We get quite high concentrations in the brain. It's a once-a-day tablet, and is quite effective in these different types of brain cancers. And we're at the point now where we have an open IND, and for those who are not in the space, that means that we've presented all our data to the FDA and said, look, we are ready to move this into humans. It appears to be safe at the doses we're proposing. It appears to work. And, what do you think? And they've given us a green light to move ahead with that. And we've gotten fast track designation, orphan designation, rare pediatric disease designation. We're working with some of the top brain cancer researchers really around the world. So we're really quite excited about the program. Well, thanks, Doug. Doug, I wanted to ask you, my brain is kind of ahead of me, but Doug, I wanted to ask you the same question. Like, what is your pet project right now?
Sure. So, with Xcellerant Ventures, like I said, we have really two theses running at the same time. We're looking for companies that we think are going to transform the delivery of healthcare through digital means, AI, even on the side of billing, get these companies hopefully acquired. We do see M&A work coming out through these health networks in particular. So that's a chunk of them. The other ones really are more diagnostics and medical devices. What we tend to look for there is a medical device that's going to have a fundamentally a positive impact on patient outcomes, such that we are convinced this is going to become the new standard of care across the globe. The last piece that we're looking at are, of course, you know, we look at how technologies are transforming the world. Well, they're going to transform healthcare as well. So you can think of AI, but we're not trying to find the AI company. We're trying to find an AI company that's going to support a broad number of healthcare initiatives. We think we've got one there. Gene editing is going to be spectacular. CRISPR field is massive. But again, what we're looking for is not the therapeutic in the CRISPR field. We're looking at somebody who is going to support all gene editing companies. We have one of those that came out of San Diego as well. So that's what we're looking for, both here and across the world. You know, we're looking at companies out of Europe and Asia and Israel as well. So it's just, this is going to change. This is an industry that has to change. It's going to get faster. It's going to get better. We have to improve patient outcomes. So like everybody here, like John and like Norm and like Greg, we're hoping to change the world. We're also an ROI investor as well, so trying to find those right deals for our investors.
Oh, thanks, Doug. And John, how many projects do you have in healthcare?
I have one particular one in healthcare. It actually came from multiple IP all coming together, but we have, I'm very big on platforms as a service. So we created a saliva powered AI platform for the early detection of chronic disease and cancer. So unlike the needle sticks or the swabs or the other bodily fluid collections of yesteryear, we combined a quick saliva collection device that could be utilized either at home or at a point of care that we are gearing to then be shipped to a CLIA-based lab within our network for a variety of lab-developed tests that we're putting forth. Everything from drug testing to cancer to heart conditions. We have 4 tests coming out this year. All of them are diagnostic, preemptive focused, with the exception of our COVID, flu, and RSV test, which is in essence influenza test, followed by an employer rehab drug test. But the aspects of pre-diagnostics for even mental health care, PTSD, those tests are coming out in 2025 for us. And the wonderful thing about challenging the healthcare status quo is if there's some amazingly smart people on this panel and that this network has introduced me to, one of our biggest challenges was how can we create a platform that could both research a marketplace, understand the needs of a market, be able to sift through terabytes worth of data, be able to collaborate on a universal platform with other researchers worldwide, and within 90 to 120 days from concept to commercialization, how can we get a test in market? And we've now achieved that twice. So we're looking forward to seeing what the future brings in healthcare, and looking forward to continue to challenge and develop the status quo, not just for a profit, but also for a purpose.
That's good. And Norm, what are you focusing right now on as far as the projects are concerned?
I mean, we're doing a fair number of things, but I would say my primary focus is working with 3 not-for-profit organizations. One to really stand them up and make them incredibly more impactful. The first is Cancer Commons, started by Marty Tenenbaum. Marty was at the San Francisco conference. Brilliant man, totally committed to patient in cancer, patient navigation, patient solutions. And so the question is, how do we support that organization that deals with a couple of hundred patients a year, a couple to tens of thousands of patients a year who need this information. The second organization is Stand Up to Cancer. That's an organization that's been around about 15, 20 years. They have a new CEO, Dr. Julian Adams. His mission is to reduce cancer mortality in the next 5 years by 25 to 50%. And he's going to get there because he's focusing in the right places in diagnostics and in AI. And what our mission is to give him the financial support he needs to get there. And the third organization is the American Cancer Society's venture capital fund, Bright Edge. And what they've asked us to do is think about how to support their portfolio companies with this type of mission capital structure. And so they've opened up their portfolio to us and saying, okay, how does mission capital support these companies for the next round? So I would say those three organizations are really what excites me the most, because that's really where the impact is, and that's really where the the move the needle opportunities are in what I call FINO. And so, you can talk about investing in real estate, you can talk about investing in oil and gas, you can talk about investing in consumer products, et cetera, et cetera. What Doug and Greg and others in this space are doing is FINO. Failure is not an option.
Right.
Okay. You're talking about people's lives from an infant all the way through. And, everybody's affected by these diseases. Health doesn't look at your FICO score. And this is where the world has to go. And we're going to get there thanks to Marty Sakata and thanks to really committed people who are on this panel. Thank you.
Thanks, Norm. How much time do we have?
5 minutes.
5 minutes. Okay. So I would say, like, for the last few minutes, let's talk about the things that really we think that are going to be a new key elements in the growth of the whole medicine. What I really mean is we know that the genetics are very important. We know the AI is very important. We know that there's not a lot of money, but we're trying to go through that process of figuring it out. I mean, even if we were to take the analogy for what used to be in the .com era when all of a sudden there was no money, but there was a lot of good companies that came out of this whole thing, and I think that the same thing is going to happen in the healthcare business, right? So what I'm trying to allude to is like, what do you think that those elements, like the AI mergers with the genetic modification technology, like CRISPR, what do you think? What's your feeling in terms of what the biggest hope is for upcoming?
Sure. As challenging as it is, certainly being on the company side or even on the fund side trying to raise capital, this is the golden age of innovation, right? There is so much going on that it's almost an abundance, it's a challenge because there's so much opportunity. I have friends who are VCs. I pity them because they're drinking from a fire hose. There's so much coming at them. And so on the one hand, we have all this innovation. It's going to take time for it to materialize, but the new tools that we have, the new insights that we're developing, the new models, the big challenge is that we look at computers and say, we can model everything. Well, we built that, right? But biology, it took 1 billion years to get where we're at. We're about 100 years into decoding it. So we're just scratching the surface. But I think with AI and some of the new tools coming out, we're getting better at building those models, better at translating from preclinical into clinical. And I think over the next 10, 20 years, which sounds like a long time, but it's short, in terms of these product development life cycles, I think we're going to continue to see some really dramatic improvements in innovations. And I'm super excited about what AI is going to bring both to early stage discovery and just making the system more efficient, because it's all about managing data, and that's what AI is good at.
Yeah, the AI right now, right? It's kind of like a silos of different knowledge bases, and then now we are able to kind of like look into different silos and then see the patterns and figure things out. But I'll let.
I'm actually going to go in a slightly different direction, because I know Greg and we are overwhelmed by how technology is going to give us entirely new treatments and entirely new ways to interpret and diagnose. But I'm going to disagree with Norm just a tiny bit, which is healthcare does look at your FICO score, and that's something that's got to change, right? So if we want to turn from purely a diagnosing and treatment system to a prevention system, which is what everybody thinks healthcare ultimately has to do, then we've got to break down the barriers for people to be able to get healthcare at earlier stages and throughout their life. And the only way that's going to happen in an economy like ours, we're not going to go to a one-payer system unless Bernie Sanders gets younger faster. We're going to have to come up with ways to really just create much greater efficiency, find ways to get healthcare into rural areas and into places outside of just a 5-mile area. You know, my partner, John, runs an incredibly large healthcare delivery system called Tribal Health. You may know that, John. I think he's got 93 tribal hospitals that he runs, and this is sort of his vision and passion in the world. One of the things that's really interesting to me is how many technologies that come to us and they're incredible ROI, and we're going to invest in them, but they're never going to help more than the richest people in the richest areas of the city. When we find different technologies that we think can now bring, for example, one of them that we're looking at basically provides, breast cancer diagnosis and mammograms that doesn't need power, that can be taken out into rural areas around the world. That's what's really going to change the entire healthcare system. I love the technologies. I love that AI is going to make a lot of different things faster and better. But until we can make healthcare cheaper, faster, and easier for people to obtain, we're never really going to change the system as a whole. So I love that we're investing about 70% of our fund into those kinds of companies.
John?
It's like he hit it on the spot. And, on putting my tribal hat on, I cannot tell you the tears that truly come to my eyes when I go across tribal reservations like Ogallala Sioux, Pine Ridge, when you have 22 people living per trailer, when the family, earnings is under, for a family of 8, is under $30,000 a year, when a tribe has a 70% addiction rate to illegal for illicit substances or alcohol, and a 90% unemployment rate. And it's not just for the tribe, it's everybody within that rural area. And that's not an uncommon story. So there is equality in healthcare that's not being addressed and has never really been addressed. And even with the advent of government assisted healthcare, we're certainly not on, even if we're on a socialized basis, the access to get healthcare, receive healthcare is challenging. And being able to address the last mile of telehealth. Telehealth is great for remote, but in order for them to prescribe, they need to be able to diagnose. And so we focused, our efforts on how can you make the current rural delivery systems more accessible. Everything from, saliva-based diagnostics testing, where you put a little, collection in your mouth, and so you don't need to put a needle in your arm to collect something that's equivalent to blood, put it into a box and ship it back. So telehealth can diagnose, and health services can now diagnose. And the other barrier is making sure that the whatever products are going into market, the thought is being put into those products so they'll be reimbursable through government-based subsidized healthcare. And that's, ironically, it shouldn't be an extra step, but when you get your product codes for the stuff that's going into market, you have to jump through some serious hurdles in order to actually create equitable healthcare. Getting it into HCA system or Kaiser or Blue Cross Blue Shield, that's an application process. Trying to get it into government assisted, the sub-insurance companies that handle these rural markets, that becomes challenging, and it shouldn't be that way. But without pre-planning those types of activities and planning for the diagnostics to actually hit home where diseases, preemptive care equates to a lifetime of health as opposed to being reactive to various health situations. Until that exists, we're going to be fighting an uphill battle on healthcare.
Norm, you wanted to wrap it up?
Well, thank you. Doug, you're absolutely right. Healthcare does look at your FICO score. Health doesn't look at your FICO score. And the what's going to drive affordable, accessible healthcare solutions is a capital structure that includes mission capital, where these companies are not driven only to create a product with the highest profit margins, but products and solutions and services that are affordable and accessible to all. And that's really where mission capital can have the greatest impact. Arthur, thank you. Guys, thank you for being part of this. Marty, always appreciate this opportunity.
Thank you very much. Appreciate it.